slide is showing a Boston spectral system, which is looking at multiple independent current control, which is kind of new on the market as well. Typically in the past, we did a single current with different electrodes. Now we have 8 contacts up to 16 contacts that can independently talk. So there's quite a bit of programming that can be done with these. Next slide. Now, looking at some of the results from this in terms of trial to implant. The summary of the slide is that if we do well with the trial, typically the implant's going to give long-term effect, 5 years or longer. Though we do have some risk with lead migration with percutaneous leads, as well as with epidural fibrosis, which can decrease the signaling. Next slide. Here's an example of the SCS procedure. The needle, basically a 14-gauge needle is placed and advanced to the lamina and walked to the epidural space. I do loss resistance with either saline or with the lead itself. And the leads are threaded through the epidural space up to the area of interest. Next slide. Here is an AP and lateral view, just typical leads up into the epidural space at the level of interest. Next slide. In terms of the actual implant procedure, we have 2 incisions, so it's actually it's very minimally invasive. On the right side here is actually Hulk Hogan, who's had his spinal cord stimulator replaced. Here in the midline, we dissect down to the thoracodorsal fascia, and on the left side here you see a lead anchoring system. These leads are then tied down to the thoracodorsal fascia and tunneled over to the second incision, which is the pocket here on the right side of the flank or buttock there, the most common places. And they heal very well, and it's very cosmetically, don't see a whole lot. Next slide. So spinal cord stimulation has been effective for long-term pain relief, improved quality of life, and successful pain disability, and has been shown to be useful for a lot of patients who have failed other things. Next slide. So we talked a little bit about post-laminectomy. Next slide. This is a slide that you can't see anything here, but this is basically a summary analysis of 34 different spinal cord stimulator studies. What the main result of this is that looking on the VAS scale, 0 to 10, which is visual analog scale for pain, that overall, on average, over the years for these studies, that patients have at least 3.3 to 4 points of pain relief with the spinal cord stimulator long term. Next slide. It brings us to a topic of high-frequency stimulation. High-frequency stimulation is 10,000 hertz, and the major advantage of this is that it does not give you paresthesias. Next slide. There's a Senza study that I want to just talk about briefly. The Senza study basically took 200 patients. Well, they had a lot of patients, but when they whittled down to about 200 patients that were actually implanted, these patients are patients that had pain for over 3 months who have failed other things. They put them in 2 groups. At the time, they used the best stimulator in the market, which was the Boston Scientific system. That was one of the older models, and they compared it to high-frequency stimulation. Next slide. So 100 patients in each group. They looked at VAS as well as musculoskeletal disability. Next group. Sorry, next slide. And they used typical parameters for this. All oral analgesics or opioids were stabilized for a month before this trial. Next slide. What they found was that there was a significant difference in both groups. Across the board, they found that both the conventional stimulation and high-frequency stimulation was good for post-laminectomy pain, sacroiliac pain, axial pain, discogenic pain, and improved VAS as well as musculoskeletal. But they found that, next slide, that actually the high-frequency stimulation was even better. So it was a non-inferiority study, but actually they showed superiority in terms of the outcomes. And you look on the right side there at VAS for back and leg pain. Even though conventional stimulation has done a very good job for decreasing pain, they've actually shown that the high-frequency stimulation is even better. Okay, next slide. So how much time do I have? Done?
1 minute.
I have 1 minute left. Okay, about 50 slides left. So I'm just going to end it here. We also do intrathecal pumps for pain relief as well as for spasticity management. This is an area that for spasticity, I think is very important for MS pain, for post-stroke spasticity pain, for cerebral palsy pain, patients that functionally can't walk and have significant pain because they can't move their limbs. Baclofen itself orally is a very good medication, but typically once we get about 80 milligrams oral, 120 milligrams oral, patients start getting significant side effects. They start getting somnolence, they start getting loopiness, they start getting confusion, and that's the limitation to this oral medication. Intrathecally, we can use about 1/100 of the dose, so the side effects become much less, and we can manage these pain states without having to have as much of the issues with the side effects. Main issue with spinal cord stimulation with intrathecal pain is that once we put these in there, patients have to see it every 2 or 3 months in order to have refills. So they're tied to the system very closely, and they lose that flexibility. I'm going to end it there. So thank you for allowing me to talk to you today.
Thank you, Dr. Chen.
One question. Can I have one question? When they do that InterStim for the blood incontinence, blood incontinence case, we do under C-arm for the lead insert. Look, you have your incision there. Are you having a micro procedure or any under C-arm procedure can do that for your spinal cord stimulator?
For the actual.
For the blood.
Yes, I make 2 incisions. So the question from urology is that they do interstims and want to know whether or not we make any sort of incision for replacement of the spinal cord stimulator.